So, an enormous pleasure to introduce our next speaker, TJ Gann, who's Professor and Chairman at Stoney Brook University in New York, ex-colleague of mine from the UK. Also, the immediate past president, the founding president of the American Society of Enhanced Recovery, who's going to talk to us about the realities of multimodal analgesia provision in enhanced recovery programs. TJ, welcome.
Thank you very much, Monty. Good afternoon, everyone. What I'd like to do over the next 25-30 minutes to talk about pain control. Why is pain control important? I can tell you, having done a number of enhanced recovery programs, initially at Duke and now I'm at Stoney Brook, where we introduced about 6 enhanced recovery programs, all at a different stage of implementation. I would say that one of the most important elements of enhanced recovery is pain control. If you can get this pain control right, your chance of success is far more than getting some of the other factors. And that's why I think that pain control is one of the most important elements of enhanced recovery. This is my disclosure. So I'm going to cover a number of different areas. First of all, how are we doing? Are we doing a good job? We are all in the perioperative physicians, and we should be doing a good job in pain control. Going to show you some data. Burden of opioids. I know that opioids has been used, especially in this country, much more than any other country in the world. We know that it's a problem. How can we potentially avoid that? Do we have some alternatives that we can use to avoid opioids? Talking about the concept of multimodal approach. Because we do have other non-opioids. And I think the challenge is using them consistently. And then lastly, just to show you some of the examples of incorporating some of the multimodal analgesia approach in an enhanced recovery protocol. So how are we doing? Are we doing a good job? Now this is a survey on patients' experience on pain. There are 3 studies, all using pretty similar methodology. The first one was done in 1993 by Carol Warfield from Boston. And then Jeff Effelbaum and I did the second study in 1999, and we repeated it in 2012. And you can see that the survey was very simple. Simply ask patients, what was your experience on pain following surgery? And again, you can see that most of the patients obviously have pain because they had surgery. But what is more alarming, if you look at over in the severe and extreme, those who experience severe and extreme pain, they are almost 30% of our patients. So these are people coming up of operating rooms screaming. Now, certainly, we don't want our patient to be in that category. And even though they are different population, you can see that we still have an important job to trying to reduce those patients more towards the slight and moderate. Now, in that same study, we asked patients, what were the side effects or what are the adverse events that you don't like? We never mentioned anything about opioids. Just tell us some of the side effects you experienced. Now, if you go through each and every one of the side effects that the patient mentioned, almost every one of them could be attributed to opioids-related adverse events. From nausea, drowsiness, sleepiness, constipation, vomiting, itching, urinary retention, almost everyone could be attributed to opiate-related. And again, this is without prompting the patients. So clearly, although opioid works well, but it potentially can come up with a lot of side effects. And we also know that poor management of pain can result in significant consequences in the process of recovery. Those patients who are teetering at their myocardial consumption potentially can get myocardial ischemia, MIs post-operatively, and patients who have pain can't go to sleep well, they can't rehabilitate well, patients who can't breathe adequately, they get infection, they get pneumonia, so there are a lot of issues with poor pain management. And we also know that now we understand the phenomena of chronic pain that often can result from inadequate treatment of acute pain. Now, in the old days, the model for our pain management has always been that if you have a little pain, I give you some opioids. If you get more pain, I give you more opioids. And if your pain is really extreme, guess what? I give you even more opioids. And you may chuckle, but this is really what a lot of us in the perioperative physician has been using, because we use a lot of opioids. And in particular, I think in the United States, far more so than other countries. I spent a number of years practicing in the UK. Coming over here, I was amazed how much opioid we tend to use, and without thinking about some of the other non-opioids. And there is recent data suggests that 1 in 10 of drug addicts, people who are addicted to opioids, they got their first opioid from either acute episode of pain or from surgery. So these are some of the people that we see every day. We potentially given opioids, and you may remember I had a very minor surgery. I was given 90 pills of OxyContin, right? And you take the first pill, and the next thing you found that you are praying the porcelain bowl, puking your guts out, and that was it. The 89 pills sits in the medicine cupboard. And guess what? People who have access to it can potentially become addicted to opioids. So this has been a challenge. Every year, every day, in fact, 90 people die from opioid abuse. Think about that. Now, not only that, in the hospital, we see a lot of opioid problems. And this is from a premier database that we mined a few years ago. And when we looked at opioid adverse events, those patients who had an opioid adverse event, and looked at how their recovery, what was their length of stay, what was their complications. And again, you can see that those patients with an opioid adverse event not only increased, their length of stay increased from 4 days to overnight about 9 days, and their cost of that episode of hospital admission increased substantially. So it's not just the opiate events, but it also increased costs. So I think the time has come. You've got to think about what are the alternatives. Rather than just giving more opioids and more opioids, there are effective ways to manage these patients without resorting, in the first instance, opioid-based analgesia. So the question really is balancing, on the one hand, effective pain management, on the other hand, side effects profile. And that is really what we are doing every day. That is what the patient is doing every day. This is a study that we published a number of years ago, and the idea was to look at patients who are on patient-controlled analgesia, a PCA device. You see the patient post-operatively, and Mrs. Smith complained of 10 out of 10 pain. And you ask Mrs. Smith, say that you have a button in your hand, you know what that button is for, right? You press a button, they give you a dose of opioids. And Mrs. Smith said, yeah, I know that is my pain button. And I say, if you have a pain out of 10, why don't you press the button? A simple question. And now you begin to hear what Mrs. Smith tell you why she doesn't like to press the button. When I press the button, it makes me sick, it makes me drowsy, it makes me loopy. So patients are trading off all the time between analgesia on one hand and side effects on the other. So when we presented this scenario to patients, and the scenario are either you have good pain relief, at the same time with moderate vomiting here, or just fair pain relief, but come with it with no side effects. Majority of patients chose not as good of pain relief, but they would rather not have side effects. And likewise, either excellent pain relief with severe constipation or good pain relief with mild constipation. And again, overwhelming majority of patients would prefer to have no complications at the expense of having not quite as good as pain relief. And that is why when you see patient who has a PCA, most of the time, almost over 90% of the time, they will never tell you their pain score is 0, right? Their pain score is usually 2, 3, and they say, I can live with that. But they know that if they keep dosing themselves, they get all these side effects. So trading off is what patients do all the time. So what are some of the options we have of the non-opioids? So if you think about how pain is being transmitted from the peripheral to the central, I think that is a good way to think about where some of these drugs work. Now we know that pain impulses started from the peripheral, traveling along the peripheral nerve to the spinal cord, the secondary neurons going up to the brain, and there's a descending control. At every level, some of these non-opioids works. For example, non-steroidal work peripherally. Local anesthetic block sodium channel, therefore blocking the signals from peripheral to the spinal cord. And local anesthetic works there too, in the spinal cord, as well as some of the other drugs, opioids, alpha-2 agonists. And in the higher centers, certainly in addition to opioids, acetaminophen, ketamine, and some of the other drugs. So there are a number of non-opioid options that do work along this pain transmission pathway to prevent transmission of these pain impulses. So just give you in a tabular form, acetaminophen, alpha-2 agonists, gabapentinoids, again, calcium channel blockers, works well, local anesthetic, NMDA receptor antagonist, and non-steroidal. So is there an ideal analgesic? Maybe I just pick one. Well, certainly this drug's thought to be the best drug since sliced bread, but every drug has its problem. And I think combining drugs is really what we are talking about here. In fact, the American Society of Anesthesiologists, in this task force for pain management, which I was part of, came up with this statement. Whenever possible, we should be employing multimodal pain management therapy. Unless contraindicated, all patients, they didn't say some patients, they said all patients should receive a round-the-clock regimen of non-steroidal, coxib, or acetaminophen. So this is a statement from our professional society, but I bet you in not consistently being done. Now we know that combining drugs work. For example, this Cochrane data shows that acetaminophen work, non-steroidal anti-inflammatory work, and in fact, if you combine both of them, they work even better. If you just look at the number needed to treat, 1.5 with 400 milligrams of ibuprofen and a gram of acetaminophen. 1.5 is a pretty effective NNT numbers, right? That means that you only need to treat 1.5 patients for one patient to be beneficial, to benefit from it. But sometimes we fail to combine these two drugs. It's a very simple thing to do. It's a very basic drugs. Unless contraindicated, we should use them. Calcium channel blockers. Again, there have been many data. A lot of data, and this is one of the meta-analyses that we published a few years ago. Again, if you use gabapentin or pregabalin, you reduce opioid consumption. At the same time, you reduce opiate-related side effects. Nausea rate, odds ratio went down, vomiting, pruritus. You do increase sedation, although there is no increase in respiratory depression. So the dose that was used in this meta-analysis is 1,200 milligrams, one single dose. And now we know that 1,200 milligrams may be too much, especially in elderly populations. Probably a more optimal dose will be 600 milligrams to reduce the incidence of sedation. Pregabalin, there's again a lot of data show that at appropriate doses, reduces opioid consumptions, reduce opiate side effects. And again, I would caution on the dose, lowering the dose would reduce incidence of sedation. Ketamine, a very old drug. Small dose has been shown to reduce opiate consumptions, reduce opiate side effects. And again, there's at least probably 50 studies show that Ketamine reduce analgesic requirement, reduce 24 hours morphine consumptions, reduce post-op nausea and vomiting. And there is some studies suggest that it even potentially have a longer-term effect. So this study in spine population shows that if you give them ketamine intraoperatively, at 6 weeks, these patients still have a reduction in pain score, a reduction in opioid consumption at 6 weeks. It certainly reduced pain score and opioid consumption immediately post-op, but even at 6 weeks, you can see there's a 71% reduction in opiate consumption and even 25% reduction in pain score. So this drug may even last longer. And those of you who have used this drug sometimes may be surprised that you can reset the opioid consumption dosing. I certainly had patients who came in with large doses of opioid. We started a small dose of ketamine. You can reset their opioid requirement, and they suddenly went down in terms of their opioid requirement. So something to think about. And in those patients, and it's fairly simple. You can give it a single dose, 0.5 milligrams per kilo. Usually I give it intraoperatively, or you can give it as an infusion, 0.25 milligrams per kilo per hour. And these are usually what I do for opiate-naive patients, but for opioid-dependent patients who come with opioids, there may be potential benefits to continue ketamine infusion. And in many hospitals now, you can send them to the regular floor without any problems. Steroids is another old drug, and it's a good drug. Steroids, we all know, it's very effective in preventing nausea and vomiting, and at 8 milligrams, it is effective in reducing pain, reducing opioid consumption. And as you can see here, there is no shortage of studies. People are concerned about steroid side effects. There is a lot of evidence to suggest that one dose of steroids, a couple of doses of steroid in the perioperative period does not increase the risk, such as infections, avascular necrosis of femur. These were the two editorials probably written within the space of a year, because there were repeated studies that showed that steroid, when used in the perioperative period, in modest dosing does not increase these side effects. And in fact, more recently, Hendrik Kellett, who pioneered enhanced recovery, starting to adopt using high-dose steroid. By high-dose steroid, I mean high-dose steroid, 125 milligrams of methylprednisolone. And that is about equivalent to about 32 milligrams of dexamethasone, a whopping dose of steroid. And again, in this patient population, in knee population, not only the patient was able to get out and about doing their rehabs, they have less pain, they use less opioids. So a single dose of steroids seems to go a long way. Now we know that local anesthetic work. Long-acting local anesthetic prolonging the effect has become popular, especially in the context of enhanced recovery. This is depot bupivacaine, which has been approved for a number of years now, seems to extend the local anesthetic beyond the 6 to 8 hours up to in the post-operative period. And more recently, there was a study that looked at using depot bupivacaine for nerve blocks. This was a femoral nerve block, and you may know that in the last week or so, this drug was approved by the FDA for shoulder block. Now, if you don't want to use long-term local anesthetic, you can simply just give a lidocaine infusion. Local anesthetic infusion in many, many studies have found to, again, reduce opiate side effects, reduce opiate doses. 1 to 2 milligrams per kilo per hour intraoperatively. There has been a meta-analysis showing at least in 30 studies that it works. What about new drugs coming to the market? Well, there are a number of interesting drugs, and some of them work in a mechanism that we know of, but others are new. And just want to go through some of these drugs, there's a long-acting bupivacaine with meloxicam combination. So this is a local anesthetic with non-steroidal combination in the form of surgical injection. So again, this is under FDA approval, but the early data suggests that it is even more effective than giving bupivacaine alone. And there's another formulation, again, a long-acting bupivacaine that is under development. And there is also a bupivacaine collagen matrix still under development. Now, there's another class of drug called the selective mu receptor agonist. So we know that traditional opioid works on mu receptors. And in fact, if you look at the pathways, it activates both the G protein coupled receptor pathway and the beta arrestin pathways. And the G protein coupled receptor pathways is involved with analgesia, and the beta arrestin pathway is mainly involved in the side effects. So this drug, olesiridine, favors more of the G protein coupled receptor pathway and less of the beta arrestin pathway, potentially giving similar analgesia to other mu opioid agonists, but reducing some of the opiate or mu agonist related side effects. Kappa agonist is another new drug that is currently under development, one of the opioid subreceptors. And there are also some of the TRPV1, these are the chili peppers, such as capsaicin, which also has been shown to help in the early post-operative period. There is some non-pharmacological methods that is inexpensive. Acupuncture has been shown to not only reduce opiate side effects, reduce morphine consumption. We published a meta-analysis and again showed that acupuncture reduced opiate consumptions by about 30% and correspondingly reduce some of the opiate-related side effects: nausea, vomiting, pruritus, urinary retention, and dizziness. So the model of what I showed you earlier of opioid monotherapy, where you use opioid for mild, moderate, and severe pain, we should think about changing to a different model. Start off with non-opioids, non-steroidal, acetaminophen, local anesthetic, and they all work. And then, if you have moderate pain, perhaps add some of the nerve blocks, ketamine, and perhaps use opioid more of a rescue rather than as a foundation. So this is a change of paradigm of pain management. Now, lastly, I just want to show you how does one integrate this multimodal approach or multimodal analgesia into an enhanced recovery protocol. Now, I want to bring you back to this study, which is the earliest study by Hendrik Kellett. This is probably his first study on enhanced recovery. Those days, they call it fast track. But if you look at their analgesic regimen, it's not that dissimilar from what we do today. And this is 20 years ago. Epidural analgesia, avoidance of opioid, multimodal analgesia, right? And trying to remove some of these tubes and drain is not that dissimilar. It's using a multimodal approach to trying to reduce opioids. And by following this protocol, he was able to get a remarkable result. And again, this was published in Lancet. And how many patients did he have? He had 9 patients. Not bad. 9 patients to get a paper in Lancet. Right? And he implemented this protocol, 9 consecutive patients, and he found that this enhanced recovery protocol, they started to eat and drink much earlier. 6 patients had bowel movement on post-op day 1, 2 on post-op day 2. No vomiting. There's some slight increase in nausea. Patient out of bed, median of 6 to 8 hours on post-op and day 2, respectively. 6 patients discharged on post-op day 2, 3 patients discharged on post-op day 3. Although there is some patient selection there, but you can see that by implementing the protocol, you can do some significant, amazing outcome, and you can see amazing outcome in these patient populations. So this is a protocol when we started enhanced recovery at Duke, And just want to share with you the analgesic and antiemetic protocol. So again, we did thoracic epidural for the open and nerve block for the laparoscopic approach. These are colectomies. And multimodal approach is acetaminophen, non-steroidal, dexamethasone, ketamine, gabapentin, and give some of the antiemetic protocols. And using that, our pain score was significantly better. The morphine consumption, if you look at traditional care versus enhanced recovery, traditional care, enhanced recovery, intraoperative opioid was significantly reduced. Post-opioid was about 4-fold decrease in the opioids consumption, and pain score, despite that, the pain score was better, right? We used less opioids. Using multimodal approach, pain score was better. And we also showed that in 50% of these patients, we saved more than $2,000. And about 30% of patients over $4,000. And that is a huge amount of savings. If you're doing hundreds and hundreds of these procedures, it adds up. And this is a slide that your CEO probably would love to see. So ultimately, what we're trying to achieve is this. This is one of the Perioperative Quality Initiative publications, and you can go to POCI website to get the infographics. It's available without charge. And it's trying to optimize patient comfort, right? Trying to get patient get onto their recovery path, fastest functional recovery, and with the least side effects. And what ultimately we are trying to achieve is what, this is the acronym that I think Monty came up with, the DREAMS. So what is DREAM? Drinking, eating, analgesia, mobilizing, and sleeping. If you can achieve all this, as Monty said, you're doing enhanced recovery. Thank you very much for your attention.